is up here doing this thing. What is that?
The heart rate.
Whose heart rate? Baby's.
Baby's.
Okay. Baby's heart rate might be basically absent. You don't like that?
Oh, yeah.
Baby's heart rate might be minimal. What are our thoughts on minimal?
Not great, but not the worst. Could be sleeping.
Could be sleeping. If this lasts very long, I might try to wake the baby up. Could just be sleeping. Or we could have a neurological problem going on. All right, then we've got moderate. Okay, what's going on with moderate?
We like that.
We like moderate.
Baby's moving.
Yep.
Doing good.
We like moderate. Okay. And then there's marked.
What are you doing?
What is going on? Okay. All right, so baby's heart rate, just your basic. And then, okay, so I've got this. This is mom's uterine baseline, if you will. Okay. Now she starts to have a contraction. Here's the nadir, and it starts to go down. This is when it started. This is when it stopped. Okay. So let's have another one. Okay. From the okay, so here's the beginning of this one. The beginning of this one. Okay. How often are you having a contraction? You base that on the beginning of one to the beginning of the other. That's how often you're having a contraction. This is how long the contraction lasts. Okay. This should be your resting tone. Okay, don't overthink that. This is really the trickiest, is how long, or is the frequency. That's really the trick. Oops. See? That's really the tricky part. Beginning of one to the beginning of the other. Okay. We have external and internal monitors. If this is an external monitor, how do you know how strong it is? Get your fingers on her abdomen. If it's internal, then we can trust it a little bit more as to how strong it is, okay? If I'm watching this baby, okay, that's kind of moderate, and then all of a sudden what's going on? Moderate, baby probably moved. Damn kids. All right. So, am I answering some of the questions that you have?
Mm-hmm.
Okay. So we're gonna draw some baby heart rates here. All right, so if my baby is coming along, okay, and right here goes down, it's a really long one, but you get the idea. Okay, and then I'm going along, what am I having? These are the early decelerations. What am I gonna do? Check the cervix. Okay? Probably get ready to have a baby. Okay? Alright. Now the baby's coming along. What is that?
Those are late days.
Late decels. They are starting later in the contraction. A lot of times at the nadir is when they start. At the nadir of the contraction. Okay? What's going on?
The cord speeds.
Nope.
It's the trouble oxygenating, recovering.
Yep. So I got some placental insufficiencies. Uteroplacental insufficiency. All right. Something is going on during the contraction that the uterus just can't keep oxygenating the baby well enough. maybe it's old, maybe it's calcified, okay? That is a problem with when the contraction's happening, it's causing too much strain on the placenta, which then can't keep oxygenating the baby.
Can that happen if the cord gets squeezed?
We're gonna see variables with the cord getting squeezed, okay? What am I gonna do here? Probably gonna do some fluids,
Reposition.
reposition, probably oxygen,
Stop the pit.
stop the pit. I'm probably gonna let the doctor know, you better check the monitors, okay? Now, I will say, just as a side note, if my baby is do, happy, 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 moderate, 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 yay, yay, yay. Happy, 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 moderate, 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 happy, 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 happy. I will watch that a little bit longer. I will try interventions a little bit longer before I panic. Because the baby's handling it well. I don't want this to continue, but I feel like I have a little bit of time to try to do something to fix it on my own. The baby looks like this. Oh shit. Okay, this I'm not gonna watch. Doc, I need you in here now, okay? All right. Okay, now we got a little baby coming along. What's that? That's your variable. That is
The cord.
cord compression, okay? Quick backup. Right now, I'm not concerned about this. I got great variability. It's happened twice. I'm gonna keep an eye on it, okay? If it's happening a lot, or it seems to be in coordination with contractions, cervical check. Okay, maybe I've prolapsed. Otherwise, what am I gonna do about this?
Maybe reposition.
Yeah, reposition, maybe beef up some fluids, depends on how often I'm seeing it. Maybe the baby already moved, and now it's resolved, okay? So I'm gonna try and get the baby off that cord, and I might beef up the cord so it doesn't clamp so easily. Okay, helpful? What questions can I answer about this?
I have a question about this.
About this? Not about this, what?
Is today's study session different than how it would be tomorrow?
Probably not. Probably not. Probably just gonna finish up material today, and then I have a review thing I'll make available to you, because we probably won't have time to do it in class today.
What review thing?
Hmm?
What review thing?
It's like I think what I have for you guys is like a PowerPoint with like pretend questions, practice questions, not pretend. All right. Anything else about this?
So it's variable, early, late. What's the A for contractions?
Acceleration.
What?
Acceleration.
I'm thinking of veal chop, and I was trying to think what the A was.
Yeah, so then, you know, if you're a labor nurse, you get into all these, does it have shoulders, which we're not gonna talk about that right now, because sometimes the baby can have like bumps before and after. So there's a lot of variables, but this is basic. Baby can have, you mentioned accelerations. We like to see some accelerations on the baby, not just the moderate variability, but every now and then we like it to kind of go up a little bit, because maybe it just ran around the block or something, okay? So we do like accelerations. All right. That doesn't erase very well, but oh well. Let's see what else is on here we need to talk about. Hypertension, hypotension. Blood flow isn't great to the baby, right? Because mom's not gotten enough tension. Hyper, it's kind of constricted to the baby, so the baby's not getting enough blood flow. Hypoxia, don't overthink that. If mom's hypoxic, baby's not getting oxygen. Hypertonic uterine activity, for contracting too much. Placental disruptions, those are your lates. Compressions, those are your variables. Bradycardia, tachycardia, don't overthink that. You know what the normal heart rate is. If it's low, it's brady. If it's high, it's tachy. If baby is tachy, in utero, check mom's temperature. Maybe mom has a fever, that'll make the baby tachycardic.
Is it 110 or 120 to 160?
Depends on the facility you work in. Check your book, because that's the values we would use, is what's in your book. And the NCLEX.
I think the book says 110.
We talked about that. We talked about that. We talked about that. What? Huh?
120 to 160.
120, 160?
I don't know,
You will not be questioned about categories of fetal heartbeat.
because it's.
This won't be specific, it'll be in. Talked about this. Amnioinfusion, what's that? Exactly what it sounds like. We're putting clear, healthy, whatever in and getting well, usually we're just putting it in because maybe we haven't got enough of a buffer in the fluid in the uterus. Okay?
What exactly are you putting in?
I think it's like an LR. Definitions, we know this. Amniotomy, just exactly what it sounds like. Augmentation, we might be giving Pitocin, we might break her water, whatever we're gonna do to, we can't say induce labor because insurance companies don't like that, so we are augmenting. I won't test you on that. There's that word, chorioamnionitis. Dystocia of labor, difficult labor, maybe it's stalling out. Episiotomy, that's when the doctor cuts it. Fern test, that's where they take a sample of the amniotic fluid and they put it under a microscope and it's like, looks like it's making a fern. Induction of labor, where we actually started, we talked about nuchal cord, oligo, you know what that means, small amount, hydramnios. So is there something wrong with the baby's kidneys that it's not urinating? You know that, poly, the opposite of oligo, premature rupture of membranes, version, we talked about that with the external movement. When should a pregnant patient go to the hospital? What do you think?
Bleeding?
Oh yeah, definitely bleeding.
Water breaks.
Yep.
If they're having a lot of pain,
Constant abdominal pain.
if baby isn't moving anymore, like they've laid down, done like the quiet room.
Yeah, what do you call that? Movement test, yeah, we're gonna check the baby out, still moving.
If the cord's out.
Oh God, I hope the cord's not out at home, but yes, absolutely, call 911 for that. If the contractions are strong and less than 10 minutes apart for an hour, 2 hours at 6 minutes for a prime-up. I think we got that, right? Leopold's maneuver, when are we doing that? Oh, come on, I really tried to do it. I think it's last page. When are we doing a Leopold's?
Shoulder dysplasia?
No. The Leopold's is when we're getting our hands on mom's abdomen and trying to figure out where the baby's position is. Okay? And that's really why we're doing it. Where's the baby's position? It's important because it's going to help me know where to put the baby monitor. And if I discover it's breech, maybe we can get it turned around. Okay, so as a nurse, I'm not going to ask you how to do it. Okay, there are steps to it. I'm not going to ask you that on the test, but it's to determine the placement of the baby.
So it's called a maneuver, but you're
Leopold's
mainly just
maneuver.
feeling it, you're not actually maneuvering anything.
Right.
Okay.
Okay, so don't worry about the maneuvers of it. Why do we need to place a small pillow under one hip if mom is lying briefly on her back? Same thing as when she's pregnant. Blood flow. We want to get her off of that major blood vessel so the uterus can get perfused. We talked about how the contractions feel. What if her membrane's breaking, call it membrane's breaking, rupture of membranes, what if it's green?
Meconium.
Meconium, what does that mean?
They pooped in
Okay.
here.
Baby pooped in utero before birth, obviously, probably because it's stressed. So I got two things to worry about. Why is it stressed? And immediately my priority, once the baby is born, is to pneumonia. I'm worried about aspiration pneumonia. In utero, why is this kid stressed? 41-week gestation, 42-week gestation, they're gonna have pneumonia. Yeah, they're gonna have it. Because that's stressful.
You could say it's straight shit for them.
Cloudy, yellowish, or smells bad.
Infection.
Probably that choreo. Some kind of infection. This one, I might not start antibiotics if the baby's doing good. This one I will. You know about fevers, is mom sick? Blood pressures, obviously high or low, can be problematic for different reasons. Are we bleeding? A lot of women's blood pressure does go from pregnancy, but we don't want to go too high because then baby's not getting perfused. What nursing interventions? Yeah, you would want to study this. Nursing interventions in each stage of labor. So what was first stage? Huh? 0 to 10. Labor starts to 10 centimeters. So what are you gonna do for your patient during that time? A lot of those things we talked about. Tell her options, encouragement, fluids, maybe get an IV started. We don't necessarily always give fluids, but we usually have an IV started. Okay? Second stage, what is that? So we're pushing. So, labor nurse, what are you gonna do while your mom is pushing? What?
Encourage her.
Encourage?
Her to breathe.
Breathe, please breathe.
Check cervix.
Not very often, but we gotta kind of keep an eye on, yeah, but not very often.
Legs back.
Yeah.
Watch the monitor.
Yeah.
Sometimes, some of them that I have, they'll put on a sofa and just like put their hand on like the back part so she can kind of feel where she needs to try to push.
Sometimes, especially having an epidural, they don't know where to push. A mirror can help them figure it out.
What do you mean?
You push to pee, you push to poop, you just push with your abdomen to do nothing. They don't know where to put the pressure. Doesn't really make a lot of sense until you're in the position to do it.
Don't you push like you're pooping?
That's why so many people.
But with an epidural, they don't know how to do that. Like,
They
don't-
can't feel it, yeah.
They can't feel it.
It is weird. It is really weird.
Is
But
that
it-
why the nurse like, kind of like pushes down when they're pushing? That's why I was saying check the cervix, cause one of my nurses, she had the sterile glove on and she was like helping the head like kind of come out more when the mom
Like she was opening the cervix?
Like she had her hands like on the lower part.
I would wonder if she had a lip
Oh, okay.
of the cervix. So the cervix dilates completely. Sometimes there's just like a lip, like you just barely feel a little ridge at the bottom, and they call that a lip.
Oh, okay.
And sometimes they'll start pushing through that because maybe it's a swollen place or something. I suspect that's what was going on there.
That's why I was like, check the cervix, cause I remember her doing that.
Get your baby catcher in there. Make sure your warmer is set up for the baby. Make sure your equipment is set up for the mom. You know, they have that delivery table. Get that in there, get that ready to go. Get the delivery provider notified. Yeah, all those things.
Plenty of towels and water.
Yeah, get ready to have a baby here, okay? And third stage, what was third stage?
The delivery of the baby.
Two.
And the placenta.
So what are you doing during that time?
Pushing the baby out.
Baby's already out.
Pushing the placenta out.
Probably the delivery provider is probably doing that. He might have you. She.
Oh my gosh, I was thinking about it. I thought you were asking what the mom was doing.
Oh, I'm
Not
sorry.
what the nurse is doing.
You
That's
as the
my bad.
nurse. Somebody is probably massaging her.
Got it.
The person that delivered the baby is probably holding some pressure, not pulling on the cord, but holding some pressure. Okay, what are you doing?
Still like encouraging her. Like
Yeah, she'll need a push
Or-
every now and then, but she'll
Not
know.
really encourage, it's like good job, like that kind of stuff. I can't think of what the word I want is.
Put the baby on her chest, skin to skin.
So we're gonna monitor both baby and mom, with baby hopefully skin to skin. We're gonna start cleaning up that room if we can. What is my priority?
Making sure baby's breathing.
Baby and mom, yeah. I'm gonna keep a very close eye on them. Are they both oxygenated well? Are we getting the vitals frequently? Is that baby being stimulated? You know, yeah, so our priority, again, your ABCs. Are we breathing? Okay?
Is it most of the time that the delivery nurse does like the APGAR, or is that like a different nurse?
It depends on your facility. At Mary Greeley, as the NICU nurse, I always did the APGAR. I did the APGAR and I did the Ballard. That was my responsibility, but
Yeah, don't they have like another nurse that usually comes and takes the baby?
Yeah, I think the NICU one.
Right,
does that.
like the NICU or like the postpartum, if
Yeah.
there's like no.
Yeah.
There's a nurse that comes and takes the baby, so
Huh?
the nurse that was doing the delivery is usually
Like,
like,
stay with the
in my room, she's usually like staying with the mom,
Mhm.
or like doing the lab stuff, like taking the blood, like doing the blood from the placenta or from the cord and putting it in the bags to send to lab and all that stuff.
Yeah.
And she'll be like a messenger kind of.
so if that baby is doing well, they need to leave that baby on mom, right? If someone is coming and taking the baby, then we're probably a little worried about
Well,
something.
not like taking out of the room, but like she's
Oh.
the one doing like those
Mhm.
like the knee things and the hip whatever and checking the butt and all that.
So at Mary Greeley, that's the NICU nurse. That's what I would do.
Yeah, that's,
Yeah,
yeah.
I think it, Methodist.
So when you said like mom and baby should be your priority, I'm like, but the other nurse has the baby.
Yeah.
So follow your hospital's policy.
Yeah, I mean, either they're both your priority or one or the other is priority. The priority still remains mom and baby. All right. What is this? Oh. Medications. You wanna go through these and look at these. Yeah. Cervidil, we put that up against the cervix. Usually the night before to help soften the cervix. I don't know enough about prostaglandin other than that we're trying to induce labor. Cytotec is gonna help with contractions. Alright, so depending on where you work is how that's gonna be given. In Fort Dodge, after a delivery, they take the Cytotec after the delivery and put it in her rectum.
That's what I was gonna ask. Is this suppository?
They do that so they don't have postpartum hemorrhages.
Is the Cervidil, is that for like an induced labor
We're
maybe?
inducing labor. Yeah. Transcervical balloon catheter, that was pretty new when I was leaving, but it's exactly what it sounds like. They're gonna put like this balloon thing up there and try to help open that up. Membrane stripping, usually they'll do that in the office, not in the hospital, where it's exactly what it said. They're trying to kind of strip those membranes a little bit, get it going a little bit. Are they completely breaking it? No. They're just kind of stripping along that skin. Laminaria, we're not gonna get tested on that. Oxytocin, Pitocin. Oxytocin is the natural hormone, Pitocin is the fabrication hormone, but we use it interchangeably. Hypertonic contractions. So they're coming fast and strong. Neither, well, so the baby might not be tolerating this, in which case we're gonna try and slow it down. And after delivery, we're gonna be worried about this uterine apnea, because the uterus is gonna be worn out, so I'm gonna be worried about postpartum hemorrhage with her, okay? If it's coming naturally, mine were all natural, hypertonic, just, I guess I have too much oxytocin, I don't know. So they didn't really do anything for me, because the baby was handling it okay. But if the baby's not handling it, you could slow down the Pitocin, there's different medications you could give to make it slow down, but usually these happen when they're on Pitocin. Potential complications of amniotomy, infection, right? Infection, maybe we might accidentally poke the kid. Just things we might do. Complete the following table. I think we've done that. Why is important to cervical exams? We do not want to do very many cervical exams, period, especially after the membranes are ruptured. Keep your fingers out of there. We are gonna watch mom's vital signs and we're gonna watch tolerating it. What is it? I didn't use this word, but what do I mean when I say a non-reassuring fetal monitor strip?
Like the lates.
The lace, or the none to minimal, or variability, yeah. That's all that means, the non-reassuring. I'm not impressed with that.
Or you have to go and repossession and all that stuff.
Listener, yeah. Shut off the oxy, or whatever we're on with. Yeah, what is that? You might have to look that up, I can't remember the name of it off the top of my head, but I can see that being a question.
The beta wall? No.
That's for blood pressure. One of you has it, I need it. Alright. What are these vacuum and forceps deliveries?
It's assistance getting the baby out.
Okay. Big problems with that is pressure on the head. Alright. Trauma to the baby's head.
To the mom.
Trauma to the mom, okay? Contraindications, cephalopelvic, the baby ain't coming out that way. It's too small, we gotta do something else. That's the beginning. Episiotomies, why do we do it?
Don't you not do them?
Research now shows we should not be doing it. Why would we do it?
To just increase the.
Yeah, cannot get that kid out, and it's just an issue of perineum isn't expanding like it should. Now we want them to tear instead of cut them. Research shows the tear heals better and faster, with less complications.
Is one way more or less like painful?
I think the cut, you don't really feel the cut when it happens, but I think the healing time to cut, I think is worse. There are different types of tears, from 1 to 4. So 1 is just not torn very much, 4 is all the way through to the rectum. Okay, so 1 to 4, it is scary.
The mom that had the 10-pound baby my last week had one of those.
Did you see it?
Yeah, I felt so bad for her.
It's just sudden, isn't it?
That was
It just-
like my first day.
Oh, God.
And she's just like sitting there, she's so sweet, just sitting there holding her baby, and she's just dripping, and I'm literally sitting there, I'm like, oh. And that made me like realize I don't think I like labor and delivery. I like postpartum, those.
So,
Not labor and
with
delivery.
her, we're worried about not just uterine hemorrhaging, but we got a bleed going on. And it's sudden, the head's there, it's there, it's there, it's there, and then all of a sudden the perineum goes,
Yeah.
and the head's out.
That
So,
baby's head was also like, cause what's the normal circumference? Like 4?
Oh.
Normal?
yeah, it's
It was
centimeters.
like 36, 38 centimeters. Yeah, very good.
Nursing,
Like a toddler.
care for her,
Ice.
ice,
The little diaper things. The ice
The
diaper
washing.
bags.
squeeze it, washing it, that spray. Stool softeners, we don't want her to have to push and break that thing open again.
If they have like a 4th-degree tear, can it like rip part of their rectum too?
It goes through the rectum,
Goes through it, so then like, does that cause any like problems with the rectum?
can, Yep. that's why we wanna do stool softeners.
I was very, blessed to have still been wearing a mask at this point, because I caught my face going, and I was just like, oh, thank God I was wearing a mask.
Okay, so stool softeners for her, pain medicines, pain medicines, pain medicines. Remember, when you sit her up, she's got this big trauma down there. She's swollen. You got an ice pack. Please let her just kind of lean or something. Breastfeeding is going to be very difficult. Teach her to feed laying down. This is going to hurt to sit on. Okay, so just kind of keep that in mind. We don't use the donuts for them because research shows that actually spreads things out rather than holding things together. So we don't do that. So infection, hemorrhage, pain management, healing. Those are the biggies with those. Oh, what can you, maybe this is what your nurse was doing. what can you do as a labor nurse to help maybe avoid the episiotomy?
Like help open the cervix.
Kind of, sort of. The cervix doesn't need held
Perineal.
open.
Massage.
Massage.
The cervix?
Uh-huh.
Like when you're doing your exams?
Well, by now the cervix is at 10, so you're not really feeling the cervix. So you're just kind of massaging around that baby's head, just to
That's
keep
what
things
she was
pliable. Yeah, just to keep things pliable.
Not during the actual labor
Encourage
though.
Just while she's pushing.
While the head's
While
hanging
she's
out.
pushing?
That's what, yeah,
While the head is
it was the
hanging out.
doctor that was doing it,
Yeah.
but just like kind of helping it go around the baby's head a little bit.
Midwife I worked with would kind of do this, so she'd be inside and outside, and she didn't have very many tears. You're just kind of massaging it. It's pretty effective. Yeah. Mom doesn't feel it, because
She's
there's so
pushing.
much going on there, you can't feel anything. What else can you do? Anything else to reduce the risk of an episiotomy?
Positioning? Can
Yeah.
that help?
Yeah, actually, yeah. All right, but really the massage is biggie. What is a VBAC?
Vaginal.
Like the
Birth.
birth after.
Cesarean.
That's right. Who is a good candidate?
Birth after?
Virginal,
A virgin.
vaginal birth after.
So I had a breech baby, so I had a C-section. Baby was healthy, I was healthy, everyone did good. I'm a good candidate to do a VBAC. What are the worries about the VBAC?
It, you're staying back for your.
Uterine rupture.
Uterine rupture.
That's the word.
Yeah, people don't usually worry about a uterine rupture because really your uterus is gonna rupture. In this case, yeah, it actually could. Okay, so think of all the complications involved there. So that is a concern about a VBAC. You've got to have emergency personnel there in case that happens.
Wait, what?
Which part?
What's the emergency complication?
Uterine rupture.
But why is that a higher? Cause it's been cut before?
Yeah, rupture right along that cut line. Yep.
What are the, like, how would you know that it's ruptured? Like, did you bleeding?
Difference in pain, yeah, a hemorrhage is a hemorrhage, so the symptoms of a hemorrhage, yeah.
Would they get that rigid? Well,
They're probably pale.
Like-
They're probably gonna go pale, their abdomen's probably gonna start.
I was gonna say, but their abdomen's already like rigid from the,
But it has a definite pattern to that rigidness.
okay, but this will be like that board-like.
Yeah, it's gonna change a bit. But mostly you're gonna see it, I mean, she's gonna get pale and. Okay.
Eyes start moving.
Risk factors for a C-section?
Infection.
Infection is huge, healing time, blood clots.
Who was a good candidate again for the VBAC?
Somebody that like, maybe they only had a C-section because the baby was breached. Baby was great, mom was great, everything was fine, baby just was breached. Should be a good candidate.
Would another risk be like not bonding with your babies, depending on?
In this
Cause I
case.
know that like some people are like, oh, like a C-section isn't an actual birth. Like, yes it is,
That's what we did our
but-
PAP on, because like, they don't do the skin to skin right away, and so like, they don't bond with their baby as quick, and, it like, makes it feel like a not normal birthing experience, so they're finding that if you do start the skin to skin right away, that it will normalize it, and they will bond faster, and they will have an easier time breastfeeding. So it just really frustrates me that they don't do skin to skin in a C-section, but they do in a vaginal.
See what that horrible pap did to taught you so much.
I know it did.
Yeah.
It was very annoying to do, I'm not gonna lie, but I learned a lot.
Yeah.
Well, that's some birth experience.
We don't usually, list that among the complications, but it can.
Yeah. I just know that it's something.
Why are we gonna keep mom NPO prior to the C-section? That's kind of obvious, right? We don't want aspiration pneumonia, have her puking. Place a wedge under one hip during the C-section, blood flow. All this blood work, cause it's a surgery. Doesn't matter that it's a C-section, it's a surgery. We're gonna have these things ready for surgery. Intravenous antibiotics, that's prophylactic, cause I'm cutting through her abdomen. Indwelling catheter. She's not gonna be able to get up right away to urinate, no matter what a trouble that is for postpartum.
Sorry. Can we go back to the wedge under the hip thing? thing? I don't think I've seen them do that.
A lot of them have a bed that tilts a little bit instead of placing a wedge under
I
there.
don't think I've seen them tilt the bed either.
Yeah, I'm sure they are.
Those are just
I've seen
kind
like they like, will get them all ready and then they just kinda like shove like a blanket right under them or something. And like, it's very easy to miss, but I had like my nurse point it out to me.
They do it very quickly.
Yeah. they
It's
just
like
kinda-
right after you put in the catheter.
Yeah.
And you're throwing stuff away, they're shoving that blanket
Yeah.
under there.
Oh.
Yeah, so you're like doing other things.
Yeah.
I wasn't on that side, so.
Let's see.
This
Okay.
is a
I
weird
think we know this,
question,
right?
Cause it's gonna hurt.
Terminology again, macrosomias, they've had, we talked about that. Multifetal, twins, triplets, whatever. Precipitous delivery, precipitous labor, precipitous birth. Really fast. Okay, so if you go into the hospital and you deliver within, I think it's an hour or 2 hours of getting there, that's gonna be called a precipitous. And there's things that might cause precipitous, labor and deliveries. One of them being drugs, illicit drugs. So again, I was always precipitous. I'm sure all my kids were drug tested. It's just one thing that can cause precipitous. Meconium aspiration syndrome, just what it sounds like. Those kids are on antibiotics and back in the NICU with them. Prolapse cord, we talked about that. Occult prolapse. Sometimes we can't really feel it, okay? If it's like right here, my head's here, my cord's here. Okay, it still gets squished, but I can't feel it yet, okay? Uterine inversion, we talked about that in postpartum, right? We don't want that uterine to go the wrong direction. Oh, amniotic fluid embolism. So the amniotic fluid rarely, but can break loose and travel and become an embolism. You'll kind of want to know how you can improve ineffective contractions. Maybe positioning. Maybe make her get up and walk if you can. Okay, there's things you can do. We talked about why this is an emergency situation. You guys taught me all about that. Did you guys talk about this, or can you tell me?
Infection.
Infection's huge. Yeah. I'm not asking a question about that. I'm not asking a question about that. Signs and symptoms of preterm labor. That might be something as simple as back pain.
Simple as what?
Back pain. Consistent tightening. So they might not call and say they're having pains, but they might say my stomach is tightening.
If it's like a preterm labor and the baby's really small, are the contractions like just as strong as like a full-term baby, or does it not contract as?
Well, so the uterus isn't as big, so it might be tracking as hard, but it's so much smaller that it really can't have force.
So it's not necessarily as painful.
Right, so they might be saying, it keeps tightening, instead of
Or cramping.
cramping, I might call it cramping.
So then that's like a sign of like.
It can be a sign that, okay, we need to check that out. Because what's the risk factors? Just all these things related to the baby.
Age.
Oh, yeah, what causes it? Yeah, smoking can, age can. Sometimes we don't know.
Life.
Sometimes an infection for the baby. Yeah, and then as far as the baby goes, then now we're worried about all those preterm conditions with the baby, oxygenation. Do you know anything about fetal fibronectin? So it is like a little, test that they'll do. If they find some fetal fibronectin, it's related to baby, then it's an indication that we're probably gonna go into labor within the next 3 days. Okay, it's just an indication, it's just something they're detecting as things are getting ready to go into labor.
Is it like a fluid in that amniotic?
Yeah. In the cervical area, I believe, or the vaginal area. So you're gonna educate her to, lay low, get some rest, stay maybe, depending on how far along she is, and come in if she starts having contractions. Maxsulfate. When do we give maxsulfate?
When their blood pressure's high, because of seizures.
Right. So I've got a mom that I'm worried about eclampsia. Incidentally, it also stops contractions.
Yeah, so then normally they're higher.
I was gonna say that earlier
Like,
when we were talking about slowing down the, I was like, I know it's not labetalol, but it's that.
Magnesium sulfate.
Yeah.
And that was kind of an inadvertent thing. Oh, it just inadvertently also
Just does, yeah. Cause it like relaxes the muscles.
relaxes the uterus, that's right,
So then-
exactly.
Literally.
Diphenhydramine, indomethacin, I don't think those are specifically on there. Terb is, terbutaline. And
What is that?
corticosteroids.
Steroids?
And terbutaline is what we give when we don't want you to deliver a baby just yet. Okay, we're gonna give you terb. Corticosteroids, we're gonna give to help mature the baby's lungs if we don't think we're gonna be able to stop the labor. Okay, we talked about the risk factors, 42 weeks. The placenta is deteriorating, baby's gonna have meconium, so all those risk factors of not having good blood flow. Talked about that, talked about that, talked about that. Oh, that was the amniotic embolism. Okay. That was very quick, I'm sorry, but it's a study group rather than class, on one of your study guides. I'm gonna make this open to you right now so that I don't forget later. And let's look at study guide 2.
Do you think tomorrow we could do like another review?
I would be available 12 to 2, so I like that tomorrow.
So we could do that, so then,
Yeah, let me know.
do you guys wanna do that?
Another question, is your exam gonna be ATI questions again, or are you making up the question?
You are not getting into ATI to do it. If I didn't create the question, I at least picked it out, but a lot of them I have created. Birth plan, okay, you know analgesia and anesthesia, that's not new to OB. A birth plan, have you seen any of them? Here, now, this is not statistically proven, but the more in detail the birth plan, the more likely you're to have a C-section. The theory is, you are so uptight
You're so stressed.
about controlling it that your body's not gonna relax. Bradley method, Dick Reed method, these are laboring methods, I don't think I asked for anything about that. A doula, like I might be a doula, I might go in with you when you're in labor and just give you kind of lay term patient advice. I kind of advocate for you, a doula advocates for the mom. Endorphins, we know what endorphins
What
are.
is E?
Dick Reed method.
Short read.
I don't know.
It's a relaxation method during labor. I'm not gonna ask any questions about these.
But is it like a breathing
Breathing is involved.
method? I've just never, like, I've never heard that. Just very confused.
I'll let you study that on your, cause I'm not asking you any questions about that. Lamaze, those have been around forever, that class that you take to prepare for birth. I'm not asking you a lawyer. Pain threshold, this is not new to OB, are you familiar with pain threshold? Okay. Pain tolerance, you're also familiar with that. Why do we want that mom to be relaxed during labor?
So that her body can push them.
Yeah, what else? When we're in pain, an area, so if a part of an area, like the heart, if your heart is not getting an area well oxygenated, you have chest pain. If you have something wrapped around a toe, that toe is gonna hurt, okay? If something isn't getting oxygenated well, it increases the pain. I want mom to relax and breathe well so that the uterus can get oxygen. Because if she's all tense and tightens up, it's not getting the oxygen it needs, it's gonna hurt worse. Okay? Cutaneous stimulation, talked about, sacral pressure, sometimes we'll put pressure against the sacrum, kind of opposing the baby's head, and that can sometimes help. A lot of this is getting through labor, and a lot of it is exactly what it sounds like, focal point, finding the point to focus on while you're having a contraction. Hydrotherapy, water, births. Right? We talked about anxiety and making more pain. We talked about that.
The water bird's only given, like, or done when you don't have a rupture of membranes.
Most hospitals, especially here in Iowa, will not allow a water birth. You can be in the water up until you're about to push the baby out, then you've got to get out.
But why?
Wait, what?
Which part?
I didn't.
Why do you have to get out?
Why?
Because of the risk of aspiration to the baby under the water.
So is it a lie that babies don't take their first breath until like they come out of the water?
A lot of countries have a lot of water births, which would prove that, yeah, that, because the water's warm and it's still moist.
I mean, the baby comes from the amniotic area, which, like, how does that?
It's just, but remember, what happens when we squish that chest and then it comes out?
Oh, it's gonna want.
Yeah. So that is such a risk.
So why do people wanna do water births?
Makes labor better. It makes the delivery a little easier for the mom. And, you know, they don't take their first breath until they get air, only a little chest thing. It is, it's a beautiful way of delivering. It's just too risky for the baby.
You know, just the people that do births at home usually are.
It's like people taking baths, that freaks me out. Yikes.
Oh, it freaks me
like
out.
every night, I love baths. Then I shower every time, but you're just like sitting in your own like, having a very relaxing time.
It is cleaned out a lot. When we have women laboring in water at Mary Greeley, we're frequently cleaning out the water.
Like a pool net?
Stone.
Or they do, yeah, water births. Hyperventilation. What is hyperventilation? Okay, so what happens when you're hyperventilating? Back to 310.
Too much
Acidosis.
So your ABGs are getting whacked, right? So how's that gonna affect my contractions and my baby?
Not enough oxygen or oxygen.
Too much carbon dioxide, yeah. Open glottis pushing and closed glottis pushing, what does that mean? A lot of people don't want women screaming in labor because that's a waste of pushing energy. When you are constipated, it helps to grunt, not scream, right? That's closed glottis and open glottis. Okay? You get a lot more pressure than, not so much pressure.
That way we tell them to tuck their chin in.
If they're having trouble with that, maybe.
So open is when they're like being audible.
Yeah.
I
Okay.
remember my nurse saying.
I was a screamer. So hypotension, we're worried about with epidurals, right? Bladder distension, because she doesn't know she has to pee. You can prolong that second stage. Theory is she can't feel where to push. Catheter migration, the epidural catheter, we don't want it moving around. Do we know when to avoid these? One of them is she addicted to drugs? I'm gonna throw her into instant withdrawal. That baby comes out, I'm gonna throw her into instant withdrawal. Or the baby's about to be born. I don't wanna give Nubane because, not because of mom, but because of the baby.
So if they're going through withdrawal, you don't wanna give them medicine?
There are Medicaid,
Are.
we don't want to throw a woman into instant, because baby would do instant withdrawal by giving her, like an anti-opioid. Nubane, we're gonna try to slow down the contractions or make them, we're gonna give them a chance to relax more between contractions. But if she delivers that baby very soon after, guess what? Now I've got a flaccid baby that I'm having to stimulate to keep breathing. So there's sometimes when you don't wanna give certain medications. I don't wanna give that baby any medication to throw it into withdrawal either. Why am I pushing narcotics during a contraction?
Cause that's the painful part.
Huh?
Cause that's like the most painful part.
And I don't
Those
want
react
so much to
fast.
get to the baby. Okay, so the Stadol, I misspoke, is also an analgesic. And why are they getting spinal headaches?
Cause of all the pressure against their spine.
Has to do with the epidural. Maybe we, need to do like a blood patch, maybe a little bit of the amniotic fluid has come out of the spinal area during the insertion or removal. That really gives you a bad headache. So they'll do like a blood patch where they take some of your own blood and put it in your spinal column area to help get the fluid built back up to help with that headache. So,
Some of the amniotic fluid came out?
no, I'm sorry, some of the spinal fluid.
Oh.
Some of the spinal fluid may have leaked out. It doesn't take much to have a severe headache. Okay, we're gonna keep her flat. We're gonna give her pain meds, of course, but she needs to stay flat. Yeah,
Can that happen if like the anesthesiologist couldn't get the epidural?
in that case, it's likely that some leaked out while he was fighting with it, yeah.
Cause he, like, the my last C-section that I got to be on, he could not do it for like 20 minutes. But the lady said that her previous C-sections, they couldn't find it until like the very end, and then they finally got it. So she had to be put under.
Yeah, that happened with mine too.
That sucks.
So then like they'd have to watch for the spinal headache for her.
If I got a postpartum mom, we can't get that headache under control, and every time she sits up, it's worse. She had an epidural, we probably have an epidural headache, a spinal headache.
Would anything like a massage like help?
It has to do with the fluid level.
So no.
I mean, it might distract, but it's the fluid level.
So then when we get in fluids,
So that's when we're gonna do the blood. All right, let's see, that's the end of, is that the end of that? Okay. All right, well, it's only 11:30. Do you want to go through some of those, practice questions together, or do you want a little break before you take the big test, or that's tomorrow?
You just do that tomorrow? Like if
can
we
we just
just.
meet with you at noon?
Tomorrow?
Yeah.
Yeah, you guys are starting to look a little dazed.
Yeah.
Yeah, yeah.
And that's
like.
fine. I'd rather study with you when you